Good evening, everybody. I know you're used to seeing Alicia, but she's had previous engagements, so I'm going to fill in tonight. So we are going to do a club webinar, and this answers a lot of our members' questions. And it's kind of interesting, the topic that I came up with for today, because it happened to be that they said, hey, can you help out with this webinar? And I happened to have answered, I think, 3 or 4 questions just that day that came into the club that we, post in our forums. And we're all about Medicare, IPPE, the initial exam, and the annual wellness exams. So there were so many questions that came in. I thought, well, okay, this was going to be a great opportunity then to go over the exams that are available to Medicare patients. And so, of course, this is through the CCO Club. So you can go ahead and post some of your questions that you need, and we will get those answered too. But if you also need CEUs, you can become a member of the club. And with that, you can get replays, you can get your CEUs that are needed for your certifications. You can ask questions and we will answer them for you. We have members who do answer them, as well as some of the instructors as well. We monitor those and try and get answers out as quick as possible to you. And then you also have some product support as well. Put in your questions, we'll be able to help you and answer everything out for you. So let's go ahead and get into these Medicare wellness exams. So Medicare does offer preventative services. Now, I'm dealing strictly with Medicare, not a Medicare Advantage plan. So Aetna Medicare, Humana, United Healthcare Medicare, any of the other Medicare alternative plans that are out there. Now, they do have to offer everything that Medicare offers, but they have that option of offering a little bit more. But definitely we need to check with those carriers for their specifications. I'm dealing strictly with patients who have a Medicare Part B plan that we bill straight to your Medicare local MAC carrier, all right? So they offer all these preventative services. So as part of the Affordable Care Act, when it came out many years ago, was that we needed more screening services available, more screening tests. We need to try and capture a lot of these problems that they were noticing. We want to try and capture them early. And the benefit to the patient to go have those done is that it will not be applied to their deductible or have a percentage of copay that they have to pay. So most carriers do that, but in the case of Medicare, they want to try and have these patients taken care of initially when they get into Medicare. So they offer 30 different services. Well, I'll go into some of them. I'll explain some of them that they have, but all different kinds of screenings are available. Now, there is a link to the web page through CMS. So CMS provides on this web page, it's actually probably one of the best websites I have seen, where you can find the exact answer that you want, the exact answer that you need. Because how many times have we been to any insurance carrier's website and you're searching in their search box and you're going through provider information and you're even looking at patient side, you're trying to find an answer to what seems like the simplest question, and they're just not available. It's not very convenient. So this website, it really is awesome. So they put like kind of little tabs or little blocks all across the screen of every different service, every one of these 30 services that are preventive medicine for Medicare patients. And if you click on one of those, it will then expand everything available under that service. So it will have a link directly to the national coverage determination. So if you've ever looked up a national coverage determination, it tells you exactly what you need to know, how they came up with it, what information they used to come up with it. Research, other journals perhaps. It will give you how long it's been in use, what changes have been made every year. So sometimes we're in a discussion with somebody in our office or perhaps an auditor, and we say, but no, that's the way it is. That's what Medicare says. And if we were to pull that up, we'd say, oh, they updated that 3 years ago. So my information's a little bit incorrect. So it tells you when the updates have been. It gives you CPT codes, ICD-10 codes, exact limitations, really any bit of information you want to know is in an NCD, a National Coverage Determination. Now, you may have heard of NCD versus LCD. So that's a national coverage determination. It means every one of the Medicare carriers, the regional carriers for your Medicare, mine's Novitas Solutions. You may have NGS, you may have WPS, you may have Palmetto. There's so many different MAC carriers out there, and I think recently just some of them changed in some states I was looking up. They're just contracts. So they bid on contracts, they're good for a couple years. So you may switch to a new carrier. And if that carrier has a different guideline, then they're also going to have a local coverage determination. So that's specifically for that area with that carrier. These are national coverage determinations. These are good for every Medicare carrier across the United States. So it does give a link so you can go directly to that information if you want. But then it gives you a summary. It breaks down that information. It tells you the HCPCS and the CPT codes that you're supposed to bill it with. There's your answer right there. Sometimes those HCPCS and CPT codes, you think, well, they're almost the same. And there's a reason for that. So CMS established the HCPCS where AMA established the CPT. So the codes are very similar, but Medicare's rule is if there's something similar and HCPCS is more descriptive, use the HCPCS. So it'll give you those codes automatically to use, so you already know what to bill. It'll give you, if there's been any updates, there's this nice little box in the corner that says, as of December 30th, 2019, this has changed. So it's really good to know that. I pulled up another one today. It said there's been no changes. So that's good to know too. That information you had before is still valid. Tell you the ICD-10 codes. How many times do we get a rejection from somebody or from Medicare because they said it's not medically necessary? And you pull it up and you say, well, of course knee arthritis is medically necessary for an injection. Why wouldn't it be? Well, perhaps we didn't have laterality, or perhaps we're using a different verbiage than what they're looking for. So they will give you your exact ICD-10 codes that demonstrate medical necessity. So if they don't have one of those medically necessary diagnoses, then Medicare is not going to cover it. And then that goes on to a different webinar that we can go into about the ABNs, the Advanced Beneficiary Notice that's supposed to be signed. So who can have these services? So the beneficiary, when can they have them? Is it, a certain amount of time after they've been in Medicare? How many can they have? Is there a frequency? Is there a limitation? It's going to tell you all that. So what exact code, what services it is that they can have. And then you can also print them. So you can make a booklet, provide it to nurses maybe in the clinical area, and then they can determine if somebody needs to have an advanced beneficiary notice signed because they don't meet medical necessity, or maybe the front office desk. So it's very, very convenient. So this website is wonderful. And this is specifically for these preventive services that are offered from Medicare. So some types of these services that they have are, of course, colorectal cancer screening. We all know those colonoscopy codes probably. Diabetes screening, glaucoma screening, lung cancer screening. So if you have a history of a smoker, they need to get that checked. They need to have that x-ray and make sure that they're not progressing any kind of cancerous tissue from smoking, medical nutrition therapy. So if this is something that you need to offer to a patient, then we click on that tab and it'll tell you everything we need to know, how often they can have these services, who can provide these services for the patient. The ultrasound screening for the abdominal aorta and aneurysm. So there's so many different things on here. We have the pap smears, the cervical cancer screenings, HIV screenings, influenza. So we have every year people get the pneumococcal or influenza vaccine. There's information on here. Which code do we bill? What ICD-10 do they want? So it's a lot of great information. So if this is this area that you're working in primary care that's offering these services, it's a great place to check it out. Now, I didn't include this on another slide, but it just popped in my head. So let's say, for example, colorectal cancer screening, because I've been doing so many audits of these lately, they have a limitation on how many screenings they can have and the frequency of these screenings, except if they're high risk. Well, what makes high risk? That information is there. So high risk, of course, you can have them more frequently. But how do you know when the patient had that last one? So if you bill it and you didn't have the patient sign that ABN, they're not responsible. So we need to know these things. My office used to do bone density scans, DEXA screenings. Well, how do we know if we had one? How do we know that patient's been in a nursing home? So the local MAC carriers have a tracking system of sorts. And you can go on and pull up that information on your local MAC carrier's website. You need to seek authorization, get your administrator to assign you a user ID and password typically. So it takes a couple days maybe. But once you are able to log into that website and access that patient information, the same with Medicare IDs, which everybody should have one now, is an adjusted Medicare ID, but you can pull up that information too. But you should be able, it will tell you when was their last screening, when was the last time they were in a rehab center, or when did they have a particular service? Do they have a workman's compensation claim out there? So those are on the local carrier and they offer a lot of great information. That just popped in my head, so let you guys know that that's out there. Once I heard that from my local MAC carrier when I went to a seminar, my coworker and I looked at each other. We're like, yes, it's about time, because we get so many denials in the orthopedics field when a patient is in rehab center. Well, we don't know that they're in rehab. They're brought in by their family member and nobody ever thinks to mention it. So to know that they're not discharged from rehab yet, that's a portion of our x-ray isn't paid. So that's why we need to know that. So now on to these examinations. So Medicare offers what they call an initial preventive physical exam, or an IPPE. And this also is one of the links on that website. Or you might call this a Welcome to Medicare exam. So that means, welcome to Medicare, that means the patient is using this benefit within the first 12 months of just enrolling in Medicare Part B. So when do they enroll in Medicare Part B? Typically, if there's no disability, it is on the birth month of their 65th birthday. So they're born March 31st, March 1st, when they turn 65 that year, they will have Medicare eligible. They will be Medicare eligible, as long as they're not working or for an employer less with a few employees, certain different criteria that must be met. But they give this only once, and it can only be done within 12 months of becoming eligible for Medicare. So if your patient just turned 65 January of 2020, they need to have this completed by December of 2020, because January of 2021 is going to be over that 12 months. Even though their birthday is January 31st, it needs to be within 12 months because they pick up eligibility on January 1st. So only once within that 12 months of becoming eligible for Medicare, they can come into the office and have a preventive physical exam. Now, this is actually one of the questions I had the other day, because there are particular components that have to be met in order to bill this code. What if we didn't do one component? What if they didn't, for some reason, perform one of those small components? Can they still bill this code? I searched and searched and searched, and I could not find anything definitive. So my answer was no, because it requires all components. And then they would just have to bill a service related to what was performed, an E&M service. What's that going to do for the patient, though? Because under this Welcome to Medicare exam, they don't pay a deductible or any co-insurance for seeing the doctor. But if you bill an E&M, now they owe a deductible perhaps, or the percentage, 20% if they don't have a secondary coverage. So unfortunately, you have to do all components of this exam. It can be performed by a physician, an MD or a DO, they are specific about that, or a qualified non-physician practitioner, an NP or a PA, or a certified clinical nurse specialist as well. So those are the people who can perform this exam. I'm going to just come out right now and say it so that maybe there won't be any questions later. That does not say so. However, this does not fall under Incident 2, because isn't this a new problem? They're coming in for something new. So you can't have the PA perform this service and bill it under the provider. So it would be a Medicare eligible provider to perform this service, okay? There is a PDF. I love Medicare. They put out CMS. They put out such great information. This PDF booklet tells you every single thing you need to know. It gives you links to places you can go to find the answer if it doesn't say it specifically, or to obtain more information. Lots of cross links, so you know if you had other questions, what other questions people had, what were some of the other frequently asked questions regarding an IPPE. There's links to that. So there's a lot of information in just this one PDF. I think this one's 10 pages long. So not that long, but easy access. If it's something you use all the time, bookmark it. Keep the information, print it out for multiple people in the office to have. So it's great information. If this is a service that's normally performed, you're going to want to know exactly what are those components that have to be reviewed. So there are 7 of them. So they need to, of course, have fully documented the medical and social history. Now, this is not information that I would suggest cut and pasting and cloning if you happen to see this patient normally. I would re-document all of this information. What medications are they on? Do they smoke? Do they drink alcohol? Do they use drugs? Are they on any opiates? Because that you have to do an assessment, an opiate assessment. What's their diet like? What are their activities? What hobbies? Do they get out and exercise? So all of that information should be documented. And I would just start fresh, brand new slate, nice clean piece of paper. Get all this information all over again. They have to do a depression screening. So, well, depression screening, what do they use? So there is a link for that. There is different templates that can be used. There's different tools that can be used. Some offices may have some kind of tablet that has this information on it that they can check box, and it will give them an assessment when they're done. There could be a form that is filled out that's offered by a society that you would fill this out and be able to get the depression screening information. The third one, an ability and safety assessment. And this is, you know, we need all of these. This isn't pick and choose. This is, we need all of these in our assessment. Daily activities of daily living, ADL. What are their activities of daily living, and how do they have any problems performing those activities of daily living? This is what we're assessing. If they're having a real big problem with bathing, then perhaps that's an assessment that needs to be done to say, well, maybe you get one of those walk-in tubs, or, you know, make sure you have a care provider in the home when bathing. Just some kind of, what are you able to do, and let's assess how safe this is for you. Fall risk. If you're on your bedroom's on the second floor of a home, you know, that can increase risk of falls. So if you have these stairs that they have to go down, what are the floors like? Shag carpeting. Maybe it's a really old house and they got really thick carpeting. Well, even if you have a walker, that's going to interfere. So what kind of fall risk do they have? And these all have information that you can just be able to answer all these questions. Hearing impairment. And this one I found interesting. I did look up what kind of screening test you have to do for hearing impairment. Does it have to be some kind of audiology sound test? Actually, as simple as, can you hear me? If they whisper it, can you whisper something? Asking them, do you have any problems hearing? That is a screening question. So you can do something as simple as that. You don't have to have somebody who works in your office who does the tones and pitches and different audiology things. Is there a problem of hearing impairment? And what is their home safety? Again, what does their home look like? What kind of, do they have pets? Do they have stairs? Do they have shag carpeting? Do they have hardwood floors? Those are a problem as well. Number 4, they have to do an examination. So again, we're meeting some of our requirements for an evaluation and management, but this is in particular. This is very specific to this patient and what they're going to be looking at from here on out. How is everything going to progress now that they're 65? Let's take all of this information under account. You know, what do you normally do? What can you do? What kind of meds are you on? What kind of problems do you have? What kind of illnesses are there? Because we all know when people come in and they do one of these cut and paste things, they typically forget something. The patient might have mentioned, well, I've changed medications, or I saw my rheumatologist last week and he mentioned I now have this. You know, so there's a lot of things that might be missed. So that's why we go over every single bit of this again. How complete are some of those examinations that are performed on a patient? So if we get the chance to do it again, now we may find something. Now we might draw something out to make a new conclusion about this patient's health and what kind of care is going to be required. And an end-of-life planning. So going over the advanced directives, going over the wishes of that patient, as well as if that provider is comfortable with that plan. Is that provider going to comply with that patient's plan? So there needs to be an agreement here, but on this end-of-life planning. So the 6th one's kind of interesting because it's education and counseling for those first 5. So if they found a problem with their opiate assessment, if they understand that there's a dietary issue there, if there was depression found, how can we treat it now? Let's counsel the patient. Let's educate them on diabetes and proper food health. Let's educate them on minimizing our risk of falls. Maybe you might need to consider a cane or a walker. Let's educate them on home safety. And during that exam, did we find something that's concerning? Do we need to counsel that patient? So very in-depth of those first 5 things. And the final one is a brief written plan, a checklist perhaps that they might give the patient to receive their appropriate screenings. Okay, based on the medication information that you gave me, you might be at risk for osteoporosis or increase of fractures. So let's do this bone mass density test or have a DEXA scan done. That's one of these screenings. So I suggest you do that in the next year. Check it off on the list. Now, what about depression screening? Okay, so we found this. I want you to go have this done. I want you to seek some help. I want you to have nutritional counseling done for your diet and the medical problems that you have. So let's check off these screenings. Have they had a colorectal cancer screening? Have they had a mammogram? Is there a chance that they might have HIV? So some of these screenings that we have based off of the information that was obtained during this visit, that's what we want to come up with a plan for them and say, okay, here's our plan. This is what we're going to do. Let's work together on getting this done. Keep you healthy and, keep you living for many more years to come. So how do we bill it? We did all of those things. We met all 7 of those criteria. We got everything all filled in. Now, granted, this visit could be taking a while. This is not something, just look at that counseling and education. This is not something you book in a 10-minute appointment with a patient. This is something that the office needs to consider as a lengthy visit. But we're not doing an E&M with additional counseling and all of these other kinds of add-on codes. This is strictly a HCPCS code G0402. That means the initial preventive physical exam face-to-face visit. This is not something that's telehealth. This is not something we're doing over Skype or over the phone or with the daughter there and the patient sick at home in bed. So this is face-to-face visit. How do we bill it? Any diagnosis. A diagnosis is required to be on a claim, always. But what diagnosis do we bill? It's not a Z1 or V or any other type of diagnosis specific to a physical, specific to the IPPE. Oh, the patient had diabetes. Okay, that's one of the things that we talked about is your diabetes. Okay, consistent with the exam that I did today, I'll bill this with diabetes. Consistent with the exam that they have hearing loss, I'll bill this with diabetes. Everything else was totally perfect on that patient. So what if you're doing this and they say, yep, I got another problem. This is what's going on. Now, is it separately identifiable? Our extremely extra important words we have there, separately identifiable. It was not part of the exam that we did. It was not part of the history that we took. It was not part of anything else that we went over specific to this Welcome to Medicare exam. If they can have something that is separately identifiable, we can bill an E&M code appropriate for the documentation of that separately identifiable component that we have of this visit with a 25 modifier on that E&M code. 25 modifier doesn't go on a G code. It goes on the 99212 code that we have. Okay. This is a suggestion, a recommendation in this Medicare PDF that lab work is not included. So if you have them coming in that day, this is not a full-out exam. This is not a physical. So, okay, let's do chest x-ray and let's do lab work and let's do all these other things. That's not what this is. So if you do lab work that day, for some reason, that patient's going to be responsible. The same as that E&M visit. So as long as the patient's aware, this may go to your deductible and you have to pay 20% for these additional services that we're doing. but otherwise lab work is not included. The suggestion is write up one of those referrals. Here, go have some lab work done. It's part of a screening, part of an assessment, part of what I need you to do to stay healthy. Have some lab work done. Because if it's done this day, they will be responsible for the lab work. They still will get their deductible waived and their copayment waived for the IPPE, but anything else you do, they're going to be responsible for. So a lot of people assume, and I've heard this over the years, that these exams are a physical, just like you go to your doctor and have a physical every year, or you're supposed to go to your doctor and have a physical every year. These are not yearly physicals. These are, hi, you're part of Medicare now. This is how Medicare works. This is how we are going to work together with your Medicare insurance to keep you healthy. This is what Medicare offers to you. So this is an introduction to what their benefits are going to be now. It's not a physical. It's not that type of exam. It's not, can you read left and right, things that we do in a normal physical. So just keep that in mind. It is very confusing. A lot of people think, well, the other thing is because you get it every 12 months, that's a year, right? Just like a yearly exam. But these are something totally different. So that's a different mindset. Explain it to your patient that way. This is a welcome to Medicare exam. Our doctor's going to work with you so that you take advantage of everything Medicare has to offer you. So, sell it to them that this is not a visit. This is not a physical. Maybe you'll get in a gown for some reason, but it's not your standard physical. This is a let's keep you healthy with your new insurance. Now, the other part of that is their annual wellness visit. So that they had the IPPE, their initial, all this information we had to gather. You have to meet all those components. All that information's gathered. Now we have a record of all that information. Now you don't have to do that in IPPE. It's a recommendation. Not every patient is mandated to do it. Okay, so if you say, oh, I'm not going to do this for you because you didn't do an IPPE within the first 12 months of getting on Medicare, it's optional. It is a service that is offered, and hopefully patients will take advantage of it. Another service that is offered is an annual wellness visit. Again, they're optional, but if you're going to bill them, this is what's required. This is where you're going to develop or update a personalized prevention plan, and you're going to perform a health risk assessment. Kind of sounds like the last one we just did. It has some of the same components of the IPPE because it's a personalized prevention plan. They are allowed once every 12 months. So if they come in January 5th of this year, next year they need to come in, well, of course, bad example, it's a leap year, but they'll have to come in at least January 6th next year, right? It has to be once every 12 months, and Medicare works that exact year there after they've been with Medicare for 12 months. So the first one's offered within 12 months of them getting on Medicare. Okay, we didn't take advantage of it. They were cruising around the world, never went to a doctor. Now they're back. Now they're back home. Now they're coming in. They've been on Medicare. Their retirement's all done. They've been on Medicare for 13 months now, and they want to come in for an annual wellness exam. It has been, the initial 12 months are already up. So now this is what you're eligible for, is an annual wellness visit. Again, not a physical, annual wellness visit. Wellness, that's what we're concentrating on, is the health risk. Prevention, that's what we're looking for in the patient. Again, it can be performed by a physician, an MD or a DO, a qualified non-physician practitioner, which is a PA, an NP, or a clinical nurse specialist, or a medical professional, a registered dietitian. is another medical professional. Now, these what those medical professionals are all described in the PDF link that I'll have for you. The first one, the only one I remembered off the top of my head was a registered dietitian. Oh, or diabetes counselor as well is another one. Or a team of medical professionals directly supervised by a physician. So if you have a diabetes educator in your primary care office, they would be directly supervised by the physician to perform some of this annual wellness visit. Okay. The minimum requirements, So you can do a whole lot more if you want, but the minimum requirements of an initial health risk assessment. Self-reported information. You have a form. They fill it out. It could take up to 20 minutes. So there's a lot of information that they're looking for. Demographics, health status, psychosocial risks. What's their lifestyle? You know, do they have, and this is where we're looking for, your family members. Do you live with them? Kind of looking for how are you mentally in the social environment, okay? Behavioral risks. Again, those activities of daily living. And those are the basic ones. You think of dressing, bathing. But now there's instrumental activities of daily living. Shopping. Can they go out and do that all by themselves? Can they take care of their own finances? Getting to an appointment. So the different types of daily living activities. These are instrumental to a patient's daily living. Document the events of their social or family. Okay, I have 3 sisters. One has breast cancer and died at age 70. My parents lived full, healthy lives and died at 95. I have 2 children. I have 14 grandchildren, whatever the case may be. You're documenting the events of their social or family lives, okay? Current list of providers. Who do you see? Who's your neurologist? Who's your optometrist? Or where do you go for your medicine? Do you go to CVS? Do you go to People's Drug? Where do you go? So who are your suppliers of care? What physical therapy do you go to? Measure their height, weight, BMI, and blood pressure. That's probably the extent of the exam minimum requirements. Those are the minimum requirements, remember. A cognitive function observation. As I'm seeing you sitting here in the room with me, can you do certain things? Cognitive functions. Depression screening, again, they have those forms or a tablet or electronic or kind of different formats. Review, again, same thing, the ability and safety. Can they perform those activities of daily living? Can they get up the stairs? Can they go to the bathroom? Different things like that. How able are they to do those? What's their fall risk, hearing impairment, and home safety looking like? Then you're going to establish a screening routine for the next 5 to 10 years. You're not at a high risk for colorectal cancer. It's allowed every 10 years. So 10 years from now, you get to have another colorectal cancer screening. But pelvic exam, maybe you're at a higher rate for some reason and you get it every 5 years. So we're going to lay out this program for them, this protocol that they need to follow to have this schedule of screenings, which is extremely helpful. When I used to ask these patients who'd come in for a DEXA scan screening, because I used to perform them, okay, when did you have one last? They haven't the foggiest clue because they've had chest x-rays, back x-rays, MRI, neurological scans. They've had so many different things done, they have no idea. It just all starts to jumble, some of these appointments, and especially if it's once every 2 years. I don't remember some things I did yesterday. How am I going to remember if in the last 2 years I've had a DEXA scan? I wouldn't be able to tell you. So they're going to establish risk factors. Okay, you have diabetes. You're at risk for A, B, and C. So let's establish these factors and figure out how we're going to treat them and care for them. That again, education, counseling, referrals. Do I need to give them a referral for lab work? Do I need to refer them somewhere to have that abdominal aorta aneurysm reviewed? Do I need to send them off somewhere? And then advanced care planning services at the patient's discretion. So for these annual wellness visits, it's optional. They don't make a patient come up with advanced care planning services. Now, if the patient says, my daughter says I should be talking to you about this, but I don't want to, okay, the daughter can't make you talk to them. So it's at the patient's discretion. If they choose to talk about this or make any kind of plans, sign an advance directive, something like that, that's up to the patient. Now they can have subsequent health risk assessments subsequently coming in for these visits. So what do we do after the first one? So we're reviewing and we're updating that health risk assessment, going over the information, redocumenting, updating that family history, updating your medical history. Oh, you had a surgery last year on your hip? Okay, let's update that information. Oh, you don't see that doctor anymore. He went out of business. Who do you see now? So, oh, I moved, I use a different pharmacy now. So updating information, remeasuring all the previous information. Is their BMI changed? How's that blood pressure doing? Let's measure all this information and compare it. How are they doing? What is their assessment of any health risks based upon those changes? We're again observing and reviewing the cognitive impairment. Is there any kind of impairment? And that's just by how they're sitting in the room, just by how they're acting and behaving. Is there anything I see that I need to review and update and document? Update that screening schedule. Oh, you didn't have that done last year? Well, I suggest you have it done this year. Or, oh, they found that colorectal cancer screening that now you're at a high risk, which puts you at every 2 years, not every 10 years. So here, let's change our calendar dates of when you have to go get these things done. You're going to update any education, counseling. Oh, you now have rheumatoid arthritis. Okay, well, that means you can't take certain medications. So for these other problems you have, let's adjust how we do things. We can just imagine all this information that's going through here, that's being said to these patients, and all of the information that's going on, all of the problems that are going on with them. What concerns do they have? What concerns do their family members have? So that's something that we need to look at and assess as well. You could furnish them with their advanced care planning services or update the information that they have. Maybe they originally said, I'd like to be on life support, and now they don't want to. So just, we're going to update that information as well. And of course, all of this is documented. So didn't document it, doesn't happen. So how do we build these? So again, we're going to use some HCPCS codes. So G0438. That is an annual wellness visit that includes a personalized prevention plan of service. So that's not something we're billing additional for. There's not some other code we're going to come up with. This code is I did an annual wellness visit and I did this personal prevention plan service. It's our initial time doing this. It's the very first annual wellness visit they came in for. Now, it doesn't matter that they did an IPPE within the first 12 months of having Medicare, because that's kind of going over what Medicare has to offer, right? Still getting over my cough. So this is different. The annual wellness visit. So they had an IPPE. 13 months later, they come in for an annual wellness visit. We're going to do an initial visit. There's some different information we took from there. We came up with a plan. We came up with not this is what Medicare says has offered to you. This is what's our plan. And you bill it once in their lifetime. So if they've had it someplace else, don't get to bill it again. They moved across country, doesn't matter. They've already been billed. So we only get to bill it once in their lifetime. 10 years later, doesn't matter. Once in a lifetime. G0439, another HCPCS code, is an annual wellness visit. Again, that includes a personalized prevention plan of service for their subsequent visit. And this they get once every 12 months. So in that 12-month period, they don't come back again for another one. 12 months and 2 days, they get to now come back for another one again. So every 12 months, they get a subsequent annual wellness exam or annual wellness visit. Updating all that information, going over and reviewing everything. So what if they did move cross country? They were living on their own, and now it's just too difficult, so now they've come to live with their children. So totally different doctor, totally different place. When they were in Kansas, they had an annual wellness visit. They had their one in their lifetime. So now that they're in Maine, what are they going to do? So the doctor in Maine is going to bill that subsequent visit. Yes, he's never seen them before. He doesn't have that information. Hopefully the patient brought some of their medical records with them. Otherwise, he's not updating the information, he's obtaining the information to include in this medical record, but it's a subsequent visit because they've already had one. It just happened to be someplace else. So again, you can bill any diagnosis with this, consistent with what you've seen them for, something that they presented during this visit that you're having. You can bill that diagnosis along with this code. There's nothing specific. You don't have to find a Z, preoperative or Z physical or anything like that. This is whatever they might have had that we encountered in the visit. I can bill along with G0438. Happen to have another problem while they're there, something else we've seen them for that is separately identifiable. So it's outside of all of the documentation that we've had in this prevention plan. Now they have something totally different, and we can bill an E&M visit. 99202 for that brand new patient that just moved across the country to live with their kids. They have a subsequent visit, but it's the first time I've ever seen them for whatever they have because they're a brand new patient to me. Something that's separately identifiable aside from this annual wellness visit. Now I'm going to bill a 99202, a 99203, whatever my documentation warrants based upon the documentation. And I'm going to bill that E&M with a 25 modifier. So just the same, I don't want to ruin it by thinking of the other preventive medicine services that we have for age 1 to 5, age 6 to 12, the other preventive medicine services that we have. Those also allow a separately identifiable evaluation and management service with a 25 modifier. So it's very similar. These are preventive services. They're just for people 65 and older or people on Medicare. So we can bill another E&M. That's okay. This one can be done via telehealth. So this is a telehealth eligible code. And that's something interesting that is on that whole website of all the Medicare information is a little phone with a picture of a person. It actually supposed to resemble a doctor because it looks like he has a lab coat on, but there's like a little phone with a screen with a person. So that's indicating that any of those services that have that little image next to it, those are telehealth eligible. So there are other screening services that are available for telehealth. Telehealth did change a lot this year. Lots of new codes came out for some services that like online management services. So we need to make sure we're following the rules correctly for telehealth. So if you have a problem, where can you go? cms.gov and search telehealth. And it's going to have another booklet that's going to pop up telling you everything for telehealth. And that just popped in my head that I didn't bring the link over. I originally did these on another, I did them personally and creating the slides, and I didn't bring my link over for annual wellness visit. So if you go to the website and click on annual wellness visit, the very first website on the first screen that we had, it will have a link there for that PDF, and that PDF is 16 pages long that describes all the annual wellness visits. So, or just, again, search annual wellness visit, and it will give you that PDF. It's a handbook that they have. So their handbooks are very handy, and they pretty much have a handbook for everything, and they have a handbook for telehealth. So again, lab work is not included, because if we're going to perform lab work during this annual wellness visit, that patient's going to be responsible. These annual wellness visits, they're not paying their deductible, and they're not paying a copayment or coinsurance. So again, this is Medicare only. Medicare Advantage might have their own requirements or their own documentation, their own pay schedule. It should be no responsibility. So because they're supposed to do everything Medicare does, and Advantage plan does as well. So if this is a service to the patient for screenings and that kind of stuff, the patient doesn't pay their deductible and they don't pay a coinsurance or a copayment. So again, you can write them a referral. You need some lab work done. You have this medical condition that requires it to be done every year, or let's check and make sure you don't have a medical condition. So here is an order. We're not going to do it today. We'll do it in the next couple months. Maybe you have to fast beforehand or something. So here's some information. We'll do it another time. You can do an EKG during an annual wellness visit. So you can perform an EKG on the patient. Again, the same as lab work, they're going to be responsible. So if they did not meet their deductible, that EKG will be applied to the deductible, not the annual wellness visit. So, or maybe their 20% coinsurance if they don't have a supplemental insurance carrier after Medicare. They might be responsible for a small portion of that EKG. So the patients need to be aware of that. They don't have to sign an ABN because it's not an advance notice, for one. And for two, it's not a service that you're not sure is going to be covered. They should cover, lab, EKG, things that you might want to do on this visit, but they don't have to waive their benefit. They just need to be made aware that you might have a small portion due if we perform this service today. So maybe they don't want to have it done. Especially if they know they're going to have to pay a portion of it, maybe they don't want to do it. So it's not something that we just automatically do every time they come in for a wellness visit, is do an EKG. No, if it's warranted by the provider, if it's medically necessary, of course, they have to have a diagnosis to go along with it that is medically necessary to perform an EKG, but the patient, it's also their choice whether they want to have it done or not. Now, what about this advanced care planning? Now, advanced care planning is another code that can be billed. We can bill for advanced care planning services. Doesn't matter how many visits, doesn't have a frequency. It's not every year, because you know why? That information might change. So I gave it a little bit of an example. Well, my daughter wants me to do this, but I don't want to. Okay, that's fine. You don't have to. This is optional for an annual wellness visit. You don't have to do that advanced care planning. But say they decided a certain plan for their future, and then they were talking to their friends at tea one day and said, well, no, we do this. And they thought about it, and they talked to their family or their spouse and said, okay, I don't want to do that. So the next time they come in, you go, you know what? I know we talked about this at the last visit, that this is going to be my plan for the future, but I've given it some consideration and I've changed my mind. Or I'm sticking with that, but now my daughter's here or my son's here with me, my grandchild. Can you explain it to them? Can you spend some time going over my advanced care plan with my family members? So they weren't able to come last time. Can we go over it again today? They may have some kind of objection or bring up something that perhaps wasn't thought of that might change that advanced care planning. So again, this is a face-to-face conversation with the provider and the beneficiary to discuss their wishes or preferences, as well as the provider's willingness to have that plan in place, okay? Again, beneficiary's discretion. It doesn't have to be done. If the patient wants to discuss it, if the patient wants to put a plan in place, if they want to change the plan that's in place, this is up for the patient to decide. So the two codes are 99497 and 99498. So we have advanced care planning, including an explanation and discussion of the directives by the provider for the first 30 minutes. Again, it's face-to-face with the patient, their family, and or surrogate. And then 99498 is each additional 30 minutes. There are no limitations to this frequency. You can have it every month you come into the doctor. You can change something new. The doctor can adjust all that information and bill everything. Of course, documentation needs to be there in place to distinguish between what you discussed this time and why it's different from the last time, and this is why I'm billing it. But there is no limitation for this code. So if you have patients who are on Medicare, patients who bring it up to you, take the time. The doctor and hopefully the providers would be taking the time to discuss it. It is a service that can be billed. So, but if the patient wants it. So that's one of the biggest things. So if we have, that is the last of the slides that I had. So if you have any questions, let me know and I can take a moment. I'm glad this information has been helpful to some of our members. Anytime you have any questions or concerns like this, or something happens in the office that day, or you heard conflicting information from a coworker and you belong to the club, just go ahead and pop that question into the forum. I personally love doing research. We all know Alicia loves doing research and finding a particular way to do that procedure, or a rule from an insurance company. Why is this state different than that state? They're just anything that you possibly have, pop it in the forum and ask us, and we'll research it and get back to you, and with hopefully the answer you're looking for. So if there's something that we can't find, we give you our best estimate based upon the business and the way things go. But most of the time, we're able to find a very definitive answer from an insurance carrier, from CPT or AMA, or some kind of source out there that your question, of course, has been answered once before. And so we are, by somebody else somewhere, and we're able to get that information to you so that you're aware of it as well. So again, I hope you guys had a good evening. And Alicia should be back here next week. But again, I will be joining you guys on March 19th. So for our next Q&A, for public Q&A. So.